Okay, so this is the facial nerve, the seventh cranial nerve of the 12 cranial nerves. Okay, so it's a mixed nerve, so it's a nerve that gives sensory innervation. So it allows it to feel things. It gives pathways for nerves to go to the brain, and you also have a motor portion in which this nerve is going to allow you to actually have actions of certain muscles of your face. And at the same time, it actually has parasympathetic innervation as well, which we'll talk about later. So in terms of the anatomy and where it starts, you should just know as a rule of thumb that the earlier numbers start in the midbrain of the brain. So the brainstem has three components: the midbrain, the pons, and the medulla oblongata. The earlier numbers, like the 1 and 2 and whatnot, they start in the midbrain. The middle numbers, like the 5 and 7, for example, start in the pons, and the later numbers, the 9, 10, 12, they start in the medulla oblongata of the brainstem. So just know, you don't have to know the actual detailed anatomy like I have here, but just know that the pons is where the nuclei of the facial nerve start. It goes around abducens nerve, which also starts in the pons, and then it leaves at the pontocerebellar angle, which basically is the border between the pons and, of course, the cerebellum. Okay, so then it will loop through to the internal auditory meatus. So auditory means like sound. So at this sort of opening here, it actually joins in with the eighth cranial nerve, which is the vestibulocochlear nerve. So a way to remember it is that the seventh cranial nerve goes around the sixth cranial nerve and joins in with eighth. So 6, 7, 8. So there's actually a bunch of nerves that come out from this opening here. And one of these nerves is the stapedus nerve. The stapedus nerve is responsible for dulling sound. So, that extra sound that, that's in the environment. For example, when you're walking in the street and there's loads of cars, they're beeping, people are talking, walking. Obviously, it wouldn't make sense to hear every single part of the environment. So there's a nerve that specifically dampens down those extra sounds that's unnecessary and allows you to focus on sounds that actually make sense. For example, if someone's directly talking to you. So, like I said, there's a bunch of nerves coming out. There's a nerve called the greater petrosal nerve, and that's formed of two things. So there's a nerve for, general sensory sensation, whatever, for the palate, the hard palate, and there's also a nerve that's responsible for the lacrimal glands. So the glands that allow you to basically cry and tear up, okay? And then we have the chorda tympani. The chorda tympani is formed of two things. So we have a parasympathetic innervation of the salivary glands, so for the submandibular and the sublingual, because there's another cranial nerve that does the parotid gland innervation. And it also gives sensation for taste in the anterior 2/3 of your tongue, okay? So this is called special sensation. If you hear special in the textbooks, that just means sensation due to taste, okay? So the reason why it's parasympathetic innervation, well, think about it, because if you look back at physiology, you'd remember that parasympathetic innervation innervates glands which actually secrete things. So it makes sense that the salivary glands and lacrimal glands are all innervated parasympathetically and not sympathetically, okay? So that's called the chorda tympani and the greater petrosal nerve. The main nerve which gives off the motor sort of function is the facial nerve proper, okay? And that will enter through another opening called the stylum massoforamen, which is sort of behind your ear. So this is supposed to be your ear. Before it carries on beyond the ear, it gives off another branch called the posterior auricular nerve. That's not too deep, but then it's going to enter through the parotid gland. So if you remember anatomy, if you ever looked at a parotid gland specimen, you'd remember that there's a nerve that went through it. And it gives off several branches. So the way to remember is to Zanzibar by motor car. So you have the temporal, which is for your forehead. You have the zygomatic, which is around your eyes, buccal for your cheeks, and mandibular and cervical. Okay, so cervical meaning neck. That's pretty much it. So in terms of the actual examination, what we want to do is we have to look for asymmetry. So look at the patient's face, see if there's any sort of deviation across two halves of their face, see if there's any things that sort of stand out. Then you get them to basically do certain actions. So You make them raise their eyebrows because that will the frontalis muscle, which is at the forehead region, that's innervated by the temporal nerve, which I just talked about. We might get them to close their eyes against resistance, so they can close their eyes, use their orbicularis oculi, which is from the zygomatic part, and we as clinicians, we would try and basically stop them from closing their eyes. It's just to test how powerful their muscles are. Then we get them to blow their cheeks, which is from the buccal nerve, get them to show their teeth, smile. So remember, this facial nerve, it's called facial, so it's all about facial expressions, okay? We might get them to even, we might even sort of test their taste sensation and put like different samples like salt on their like anterior part of their tongue. Because remember, the posterior sensation is from a different nerve, so this is from the glossopharyngeal and the vagus nerve. We might even get them to ask them about have they had any history of hyperacusis. Hyperacusis is a great sensation or an overstimulation of sensation of hearing, and that makes sense, right? Because I showed you that the stapedius nerve is what dulls sound. So if you have a lesion there, you can have hyperacusis. And lastly, the corneal reflex, which I'll talk about soon, okay? So in terms of the diseases that you can get, the lesions, we can have a hemifacial spasm, which means on one side, there's basically contractions of different parts of the facial nerve. That's not really important. What's important is the Bell's palsy, okay? Bell's palsy is an infranuclear lesion, and that might not make sense to you now, so here's me explaining it with this diagram here. So the facial nerve is a very complex nerve, okay? It comes from the brain on both sides, and then it enters the nuclei of the facial nerve, which is in the pons, which is this part that I'm talking about here, okay? And the nuclei of the facial nerve has two parts, an upper and a lower part, or a supranuclear part and an infranuclear part. The supranuclear part is bilaterally innervated. That's the high. If there's one thing you're going to take out of this video today, it's that the facial nerve's nuclei is at the top, the superior part, the supranuclear part is bilaterally innervated, meaning that the right, so basically the supranuclear part gets innervation from the right side and the left side. So if you look at the purple nose, look, there's one going down and from the right hand side, and there's one going down from the left hand side. So think of neurology like an electrician or like a wires or a circuit. If this was to get destroyed or damaged, you have a left side that will back it up and provide innervation. So that means, so these supranuclear parts, they innervate the top part of your face, and then the lower part of the nucleus innervate the lower part of your face. But there's a difference, because the lower part of the nuclei are only innervated on one side. So the left side, look, the left side goes down, there's only nerves going towards this side, and it decussates, so it crosses over. So if there's a lesion there, you basically get nothing, because there's no backup from another side. And same with the right hand side. The right hand side is going to go cross all the way down, and it's going towards the left side, and there's no backup. There's only two nerves that will go to that lower nuclear part to innervate the lower side of the face. So hopefully that makes sense, because now this is Bell's palsy. It's an infranuclear or even a nuclear, so on the nucleus or below the nucleus lesion. So if you look at this guy here, we can see that half of his face is okay, but his right hand side is destroyed. So it's a peripheral nerve lesion, which means that the nerves that are coming out after the nucleus. So you can see that the purple nerves, which is for the forehead, if we track back and where they're coming back from the upper part, okay? And it's both nerves that have been damaged, so there's no backup, that's it. The nerves which innervate the the part of the face, they're gone. So you can't basically raise your eyebrows anymore. Same with the lower part of the face. If you track back about where the facial nerves, so these nerves are coming from, they're coming back all the way from here and then from the left hand side, which means you can't even innervate your lower part of the face. Whereas the other side is completely fine because nothing's happened to it, okay? So what would you see clinically? Would the patient be able to raise their eyebrows? Well, no, because if you look at the purple nerves, they're gone now. So they have a drooped face, they cannot raise their eyebrows. So it looks like a stroke, yes, but a test to see that is you get the patient to raise their eyebrows, and if they can't, then you probably know it's a peripheral nerve lesion and not a central nerve lesion, which is a stroke. They may get extra symptoms like hyperacusis, because again, that nerve, the stapedius nerve is gone. You may get loss of taste and sensation because the chorda tympani is gone. Maybe some salivation decrease, because I told you about the chorda tympani again, that's gone. And actually, there's a little phenomenon called the Bell's phenomenon. All right. So because they can't close their eyes, because I told you about the all the nerves for the upper nuclear part is gone. There's a phenomenon where even if they can't close their eyes, but even if they try to do so, their eyeball is gonna try and like compensate and basically look up, and it's called an upwards eyeball movement. It's known as Bell's phenomenon. Okay. So now we're going to look at what happens in a supranuclear lesion, so anything above the nucleus, from the brain to the nucleus. And this is basically like in a stroke, for example. So if we put a knife here, okay, and we break off all these nerves here, let's see what's going to happen. Okay, there's a nerve going down from the right-hand side to the superior part of the facial nucleus, right, on the right-hand side. So one of the nerves for the upper forehead is gone, okay? Then we look at the two green nerves. So all the nerves for the left-hand side of the lower nuclei here is gone, okay? Then we have one of the nerves from the going towards the upper part of the other side is also gone, okay? But it's only the upper part of the face is completely fine, and I'll tell you why. Because there's a left wire, if you think about it, backup, in case this red one, sorry, the right one went out. So the right one went out, we have a left side that's actually gonna provide a backup innervation. That's why they can still raise their eyebrow on their right hand side. Same with the left hand side. Even though the lesion took out this nerve, you have this this left hand side nerve providing innervation towards the forehead. So that means they can still raise their eyebrow. Okay. And obviously these nerves here, the left hand side, is still working fine. The only part which isn't working is the two wires from here. Hopefully you can see that. These two wires here, which basically have been damaged by this, the knife, the stroke. So if you track down where these nerves are going, they're going towards the lower part of the face on the opposite side, because they've been crossed over since after coming here. So from the right hand side, the left hand side, the lower part of the face is gone, basically. So only the contralateral lower part of the face is affected, and their forehead is spared. So basically, if you get the patient to raise their eyebrows, they can raise their eyebrows. So if a patient has these sort of drooping face symptoms, but they can raise their eyebrows, that might be a huge red flag, and you might want to take them to an emergency specialty ASAP. Other sort of symptoms, which is kind of important. So herpes zoster, this is basically like reddening vesicles that are formed in the external acoustic meatus, basically in the ear. So think about like how the anatomy is kind of like, if you look here, the internal auditory meatus, where the vestibulocochlear nerve, it kind of makes sense that therefore there's going to be vesicles forming near the ear part in the external acoustic meatus. That's called Ramsay-Hunt syndrome. And herpes zoster can actually lead to Bell's palsy, okay? So it basically occupies the dorsal root ganglion of the nerves, but that's not really important. And yeah, that's basically a whole summary of the facial nerve. Hopefully that was helpful.